Good morning. Welcome to this morning's discussion on the heart attack. This is Psyfeld. So for our medical students, where would you like to start? Any particular character or scene? And given where the mics are, project.
I guess we'd start with George. It's kind of the center of the episode with his illness, anxiety, and pursuit of alternative medicine.
Right. So let's say a couple of words about alternative medicine first, because there's not much to say about it in board prep, which Psyfeld remains focused towards. Where to start? So I think the easy segue in terms of what might be of current interest in the literature is the use of once illicit substances for medicinal use, and more specifically indications in psychiatry, and most specifically indications in psychiatry that are likely to appear on a medical student's shelf exam. Right. So along those lines, right now cannabis has no value. There are no double-blind, placebo-controlled studies, and the FDA has not approved cannabis. That's whether it's in the hemp form or whether it's marijuana, THC, for management of any known psychiatric disorder. The same, however, cannot be said for the psychedelics. There is emerging evidence that the psychedelics may be helpful. And we're not quite at phase 3 trials yet, but they'll be soon. And there's significant optimism. And of primary focus are the anxiety disorders, including post-traumatic stress disorder, as well as other substance use disorders. And that includes even tobacco use disorder, so for smoking cessation, okay? And I think, and this is a very uneducated and uninformed eye just reviewing the literature, that's me. Psilocybin, ayahuasca, and LSD probably top the list of hallucinogens, and of course ketamine, which has gained FDA approval already for treatment-resistant depression. And while the effects are robust, unfortunately, it's been reliably shown to be transient. Right? So maybe in emergent settings of acute suicidality, unfortunately, individuals do require repeat doses to maintain that effect. So again, we think of dissociatives, and that would be ketamine. Then we could think of psychedelics. That's where ayahuasca, that's where psilocybin, and that's where LSD would be categorized. The other subcategory of hallucinogens are the deliriants, which are largely anticholinergic, that right now do not appear to have much clinical value. And as we understand, certainly having rotated on a consult service, can actually induce delirium, right? So again, very brief primer of what you might see on a shelf exam. Beyond that, I wonder if I'm missing anything when it comes to other substances, alternative substances for the treatment of mental disorders. I'm going to resist the temptation to kind of segue to other modalities like electroconvulsive therapy, transcranial magnetic stimulation. We'll hold off on that for now.
What about, are there any important alternative medications we should consider in terms of contraindications with commonly prescribed psychotropics?
Not beyond what your friendly neighborhood pharmacist will need to review. And that is clearly beyond the scope of what we can discuss today. You're always concerned about not only medication interactions, that is, taking a medication like a psychotropic with another prescribed medication, resulting in either elevated or lowered blood levels of one of the medications, that is the one that is the substrate, interacting with one that may be an inducer, therefore lowering the level of the substrate, or an inhibitor, therefore increasing blood levels of that substrate. The one drug-to-drug interaction that does tend to come up on exams will be taking two serotonergic drugs that could act synergistically. The serotonergic drugs can be prescribed. The SSRIs are the easy example, and they're usually the culprit because on a psych exam, there's depression, there's the prescription of the SSRI, and then there's the rest of the paragraph, there's the rest of the vignette that shows someone who is now delirious, right? And when you see that, that is a delirium in the context of upper motor neuron signs, so myoclonus, hyperreflexia, so brisk, deep tendon reflexes, and then even perhaps some GI symptomology. We have to think of the serotonin syndrome, right? Similarly, an individual can take multiple sympathomimetics. Again, they can be prescribed, but they can be substances that are not prescribed. That includes over-the-counter as well as recreational use. When taken together, can result also in delirium. But in this case, the delirium will be related to an abrupt rise in blood pressure. So what you're looking at there, I think within psychiatric circles, and therefore on a psych exam, a shelf exam, is called a hypertensive crisis. And then outside of psychiatry, the hypertensive emergency, those two clinical terms are synonymous. They're interchangeable, right? The general definition is that there's an abrupt rise in blood pressure. The diagnosis is not blood pressure numerically defined, but it's an abrupt rise in blood pressure with signs of end organ damage. And of course, delirium is an example of end organ damage, that end organ being the brain. The hypertensive urgency, on the other hand, is by definition an asymptomatic patient with an abrupt rise in blood pressure. And there, you do need to know those parameters. And I think the last time I looked, it was about 210/120 in terms of defining the hypertensive emergency. And the treatments are different. The treatments are a bit different. So keep that in mind too when you're looking at and you're reviewing questions on shelf exams. The hypertensive emergency / crisis versus the hypertensive urgency, when two medications that are both have sympathomimetic qualities may be taken or ingested simultaneously or together. Other questions about George and the tour, right? And the healer.
Oh, yeah.
Right. And you guys were looking at me like, I got the right episode.
He was very physically funny, very physically comedic.
Yeah. And what's interesting, I wonder, in terms of, and I don't know about grass or tree bark, in terms of a sympathomimetic effect resulting in a heart attack, which of course wasn't a heart attack, but might that particular scene have been suggestive of the hypertensive crisis? Right. Well, may George have been taking a medication with which the bark somehow interacted. Now, there are psychedelics made from the bark of Amazonian trees, right? So it's something to consider. But then again, I'm not sure if those psychedelics would actually have sympathomimetic qualities as much as they would serotonergic qualities. So maybe not a heart attack, but maybe that is Larry David, should have provided George in the script symptoms suggestive of the serotonin syndrome. That may have been more medically accurate.
On the topic of drugs, you could make perhaps a connection between his purple discoloration and some of the drugs that cause like pigmentation changes. I don't know if anything changes the skin color that.
No, well,
I thought you said
no,
cyanide.
like yeah, purple. I'm trying to think.
Isn't there something that changes skin color? I forget what it is though. Maybe not like that, but
Thorazine or chlorpromazine, you could have
retinol or
that's retinol. That's not skin, to my knowledge anyway.
Yeah.
Trying to think. There's a test for ketamine that turns the reagent purple.
Oh.
Right. I don't know the name of the test. I could post it on Twitter later. But there is a test for ketamine where if you put in the reagent, it'll actually turn the liquid purple, or the sample purple. Getting back to George and the use of, in this case, hallucinogens, albeit dissociatives. All right. let's talk about George's behavior beyond his and Kramer's desire or interest in alternative healthcare. So I heard illness, anxiety tossed out there. So here's the algorithm that I want you to consider, right? And it's just a review of what we already discussed during the somatic symptom lecture. When an individual presents, we'll call him George, with a chief complaint that is not supported by your clinical exam. So history, physical, and any laboratory or diagnostic workup. One of the first things that the physician must consider is whether the individual is making a conscious effort to provide misinformation. And if you don't have that information, if you don't have, for lack of a better word, proof, your patient is always telling the truth. And that's irregardless of your gut. That's providing unconditional positive regard. So your default should always be that they are not trying to deceive you and only change from that frame of reference when you have verifiable evidence that the alternative is actually true, right? So in a case like George, do we have any evidence that would suggest or lead us to believe that he is providing misrepresentation or misrepresenting his symptoms? No. If the answer is no, then our differential quickly defaults to a somatic symptom / related disorder, including somatic symptom disorder versus conversion versus illness anxiety disorder. Now, the way the DSM is currently categorized, we have those three really in our differential diagnosis, and they might be letters A, B, and C on your shelf exam. In two of them, the individual will actually experience symptoms. In the other, they are preoccupied with the symptoms. So while these can co-occur, they're really not the same. And I would suggest that maybe in the DSM-6, illness anxiety disorder, the condition previously known as hypochondriasis, will actually be removed from this chapter and placed in the obsessive compulsive and related disorder chapter, because illness anxiety disorder has the A word in it and belongs in one of the anxiety spectrum disorder chapters. Right? But nonetheless, it's currently categorized where it is. When I provided the PowerPoint to you a couple of weeks ago, we did reference illness anxiety disorder. For George, do we think that things are clinically significant due to his preoccupation with having or acquiring an illness? Or do you believe that he is actually achieving clinical significance, that is, experiencing clinically significant distress or impairment due to actual symptoms?
I think the evidence that we don't see as the physician, but his friend sees that he's not achieving clinical distress in the long run. Like even when he was having a heart attack in the diner, he was trying to tell the waitress, you got the number wrong. You got to fix that check. And his friend Jerry mentioned that before, when they were running an anorexia special on TV, he'd been eating for 2 weeks. So he sort of just, I would say, being over anxious about the possibility more so than the actual symptom.
Right. And I agree. And for that reason, the most likely diagnosis, if George were to present on a shelf exam, would be illness anxiety disorder.
My initial thought was conversion disorder because of the immediacy with which the symptoms set on.
Right. Yeah. That's so the onset does fit with conversion. If hypothetically this were more symptom based and less based on George's affect, his preoccupation and worry, our differential would be somatic symptom disorder versus conversion. What is the difference?
So my understanding is, I feel like I'm a little bit unclear, but conversion disorder is more neurological symptoms that don't have a clear neurological focal relation, but then somatic symptom could be any complaint, i.e. chest pain.
Yeah, that's it. Yeah,
neurological.
that's it. And in that way, and the way you stated it, allows us to say that conversion disorder is probably just an example of somatic symptom disorder, when the somatic symptoms focus on or manifest as deficits in voluntary motor and or sensory function.
So can you tell me if my understanding was incorrect? Because my understanding was that conversion disorder is the difference is that somatic symptom disorder is a much more gradual onset, and conversion disorder, you can almost point to the event that happened that caused it.
That is consistent.
Okay.
Yeah, of course, it doesn't always happen that
Yeah.
way, but that is consistent. Yep. But again, in a shelf exam, be very careful because someone who writes these questions can easily have a more spontaneous appearing onset
Mhm.
for somatic symptom versus conversion. And your primary focus should be on what type of symptoms.
Okay.
Right?
I also just want to check, at least in the practice questions I've run into for somatic symptom disorder, one of the primary concerns is that the symptom will develop into something more serious.
Mm,
Whereas for conversion disorder, and I know this isn't necessarily true clinically, but in the vignette presentation, it's usually like label and difference, where they're not concerned about it progressing from, like, say, a mole to a melanoma.
Right. And that really helps distinguish it from illness anxiety disorder, right? So labellin deferens, just for people who may not know, is a descriptor of one's affect. So there are usually 5 different domains of affect that we comment on upon providing a mental status examination. The first is the type of affect, which is pretty intuitive, right? Is the individual anxious, dysphoric, etc. Then when we talk about the range of affect, we talk about the intensity, specifically the average intensity over the course of the entire eval, right? Which is usually 60 minutes. We have change pattern, and then we have appropriateness. Labellin deferens is a clinical term, used to describe the appropriateness of one's affect. So if an individual came in with acute onset of unilateral blindness, we would expect them to have anxious affect. When they don't, and they are very calm appearing, we might call that inappropriate. That would be correct. But in the setting of conversion disorder, the inappropriate affect has a specific name. So all labellin deferens is the inappropriate affect observed in the setting of conversion disorder. So be very careful. If your clinical vignette demonstrates or depicts someone with conversion disorder, you may have inappropriate affect as choice A. But if you're asked the single best answer, go to choice D, because if it's or C, of course. But read the answers closely, carefully, and the single best answer there will be labellin deferens. Right. So anything else with George?
Quick point about so George's symptoms seem distractible. Like the waitress comes and then kind of his chest pain goes down, or the person in the bed next to him is bothering him, throws something at him. Like he's very distractible. Does that fit into our definition of somatic symptoms?
You could see it in all the above. Even if we switched columns and quickly got ourselves in the proverbial column B, when all of a sudden we discover evidence that the patient is deceiving us. So distractibility, unfortunately, cuts across all of the above. And I think distraction is one of the bedside maneuvers that we actually might consider. And I'll have you refer to your PowerPoint slide. Unfortunately, while it does allow a differentiation from a quote unquote organic pathology, it doesn't differentiate between the disorders. Once we begin that algorithm of somatic symptom and related disorders, and that the related disorders would also include those 2 conditions when the patient is found to be misrepresenting their symptoms, that is both factitious disorder and what was formerly known as malingering.
On that topic, I was also we initially determined that he wasn't consciously, I don't know, for lack of a better word, faking or making up his symptoms. Yeah, but something that I was thinking towards that direction was something that comes up a lot in distinguishing factitious and malingering is that factitious disorder patients will be very amenable to further workup, but malingering patients won't. And he was not thrilled about the tonsils getting taken out. So he doesn't really want more health care. He just had that symptom.
Right. It doesn't appear that George really is guided by what we usually refer to as secondary gain and adopting that sick role. All right. The other thing I want to bring up about George is that through this process, especially when he is hospitalized, he actually looks like he goes through the 5 stages of grief too. And I just wanted to highlight that when he begins to talk out loud about if I ever get out of this hospital, ... he's bargaining, right? So what are the 5 stages of grief? And let's talk a little bit about the depressive disorders.
Denial,
So we have denial,
Anger.
bargaining,
mhm,
acceptance.
depression. Yeah.
Oh,
But what is
Yeah.
that? Is that before acceptance?
depression is before acceptance. It's the way Kubler-Ross originally designed or proposed the theory was that it would be second to last. It's just before acceptance. Yeah. Now she has since revised that. People don't have to linearly navigate through the 5 stages. They could also be fixated at a stage. They could regress back to a prior stage. They could certainly skip a stage. So, but those are the 5 stages of grief. And the reason why I wanted to briefly bring this up is to introduce maybe a clinical scenario in which the individual does not resolve their grief or the grief reaction and therefore does not achieve acceptance. All right, so maybe they get to depression, if we want to keep this as a linear teaching model, and now they come to clinical attention. So by definition, bereavement is not clinically significant, so it is not a mental disorder. But when the individual is bereaving and does demonstrate clinically significant distress or impairment, we change the name because then it becomes a disorder. Anybody recall the very long name of it?
Persistent complex bereavement disorder.
Yeah, exactly right. Right. Persistent complex bereavement disorder, usually abbreviated complicated bereavement. And all it is, again, is either qualitatively or quantitatively beyond that which we would expect from bereavement or grief. Those 2 terms are usually interchangeable. Grief is the feeling, bereavement's the syndrome, but we usually interchange those 2 terms. In either case, they're defined by there not being clinically significant. Once an individual demonstrates clinical significance, persisting complex bereavement disorder, which of course then increases the risk for a major depressive episode. So that's the usual progression. Wow, anything else with George?
Just like his personality being so influenced by Kramer versus,
Sure.
yeah.
Yeah. Yeah, he significantly low self-esteem, very suggestible. Well, you would love this character in a hypnotherapy session. And consistent with that idea, the speculation that he has an extremely low self-esteem is that when they're in the hospital, when he's in the hospital and he gets visitors, when there's a conversation that kind of turns and focuses on Elaine, he's the one that shouts out, "What about me? Or I'm the sick one." I'm paraphrasing, but he needs the attention put on him. All right, what other characters you want to discuss? We're actually 20 minutes into it. This is quick. We only have like another 5 minutes here. Tour. Yeah. So for those of you who attended Fiddler last night, Tour was actually not as in character, of course, but same actor, was in Groundhog Day. So we get to focus on this character and the most. Yeah.
Yeah, I did not make that connection at all.
Ted Myers.
They're
Yeah.
like dressed so differently.
Yeah, a little different, right? Yeah, I mean, different characters altogether. Of course. Well, what you don't know about Tor is that after a career in as a healer, he actually went on to sell insurance. But,
The natural progression.
right.
Yes.
So, he makes a comment that I think we need to discuss, but unfortunately, really can't get into this topic too much today. Quote unquote, I lived with the Eskimos many years ago. Then he goes on to describe their behavior. You may recall his description. Yeah.
Oh, in the snow.
Yeah. So, yeah.
Oh, yeah.
Yeah. So you can actually have a clinical vignette on your shelf where an individual from the Inuit culture does the exact same thing. And if you see Native Canadians putting their heads in the snow and quote unquote acting hysterically, single best answer? Well, if it becomes clinically significant,
Okay.
distressful, it's a culturally bound syndrome called kadlokto, otherwise referred to as Arctic hysteria. And that has appeared on exams before.
What's how do you spell it?
PIB, I think it's LOKTL, kadlokto. You have to check the spelling. Although in a multiple choice shelf exam, you probably
Good
don't.
figure. Are there any other interesting culturally bound syndromes?
Tons of them,
Okay.
tons of them. So, yeah, so the dissociative episodes, screaming, usually not appropriately clothed. in terms of the Arctic temperature, and then sticking their heads in the snow. So he describes a culturally bound syndrome. What I want you to know is that when we look at these types of syndromes, and the emphasis here has to be on the word syndrome, right? And that's a hint in terms of the way the shelf exam question might be posed. We have to often differentiate these conditions like the blokdo, from culturally sanctioned behaviors or beliefs. Okay, because in both situations, they are usually geographically isolated and will be geographically isolated on shelf exams. So we see geographically isolated behavior, answer A, culturally bound syndrome, answer B, culturally sanctioned belief/behavior. The differentiation is that in one situation, the culturally sanctioned belief, I want your focus to be on the word sanctioned. That is, within that geographical location, the behavior is deemed to be normal, right? Almost 10 times out of 10, when you actually are provided a question on the shelf, the board is going to look for you to answer normal behavior or nothing further to do, right? I think a minority of the time, I would say about maybe 30 to 40% of the time, you may have to come up with the actual name of the culturally sanctioned behavior. But I think greater than 50% of the time, they're looking for normal as the single best answer. Right? One example of a culturally sanctioned belief is hoodoo, that's with an H. That is root work, which is indigenous to individuals living in the Southeast United States, specifically the Bayou region of Louisiana, right? Where spells and brickwork keep away evil spirits. Person from Louisiana gets on a flight, lands at North Liberty, puts brick dust down, Terminal A. They may be accompanied, they may be escorted to acute psychiatric services for an emergent psychiatric evaluation. And if you're on call with me, when you give me a call and say, I want to run a case by you, I better hear that normal behavior, nothing further to do. Discharge the patient, right? On the other hand, culturally bound syndromes, I want your focus to be on the word syndrome. That is, although similar to the culturally sanctioned belief, this too will be geographically isolated. Within the geographical location, the behavior is considered to be abnormal. Pabloco is one of those examples. In this case, about 100% of the time, they will ask you the specific name or label of the behavior. Pabloco, again, is the example we see in the heart attack. Any other thoughts on TOR? We're going to end it here. We're right at the bottom of the hour. So we're going to ask folks following at home to give us a couple minutes. We're going to just change venue and jump on to table rounds over Zoom, and we'll see you there.